Bismillah ar-Rahman ar-Rahim. Well, it's a great pleasure to be a moderator in such a nice presentation or a course, which is about male infertility for non-urologists. This course is organized in collaboration with Saudi Society of Men's Health and also the Saudi Society of Obstetrics and Gynecologists, and by the sponsorship of Sprout Company. And it is my honor to present my dear friend, my colleague, Dr. Khalid Al-Rabi'a, whom I always enjoy his talks. Dr. Khalid Al-Rabi'a, he's a urology and andrology consultant in King Abdulaziz Medical City, and he's an associate dean, clinical and simulation affairs in King Saud bin Abdulaziz University for Health Sciences. So I would leave the floor now for Dr. Khalid. But before I leave the floor, there is just a comment for the audience that we will give time during the talk for the question and answers, which should be typed in the question and answer domain in the lower part of the screen that you can see. Dr. Khalid, can you start, please?
Thank you, Dr. Ayman, for the wonderful welcoming. And I would like to thank the Saudi Society of Men's Health for the invitation. It's an honor to present in this prestigious society. I would like to thank Prof. Saleh bin Saleh, Dr. Raed Al-Mani, and also Dr. Abdullah Al-Jarbour for all this great efforts in this well-pronounced society. So my talk today is going to be tailored for non-urologists about male infertility, how to approach. I'm trying to, I'll make my presentation more of case scenario-based, interactive. In the middle of my talk, as Dr. Ayman said, we're going to have question and answers, so we can try and make it more focused for each case scenario. So to start, infertility is usually defined as inability of a couple to conceive after 12 months of regular unprotected sexual intercourse. The incidence worldwide is around 20%, and up to 50% is secondary to male factor. And of this male factor, 30% are deemed idiopathic. Surprisingly, with this high number of male factor infertility, still female factor are often viewed as responsible. And a study that was done in 2012 showed that many male partners not evaluated at the time of infertility assessment. And in the ASRM in the back in 1998 showed that in a survey that 20% of partners of women who presented for infertility evaluation only had the partner evaluated. So we'll start with the first case. This is a 32 years old gentleman married to a 28 years old female who had a normal evaluation by her obstetrician, and they were having primary fertility for the last 2 years. He had an unremarkable fertility history and past history. The semen analysis that he had showed a volume of 3.5 cc, a concentration of 9 million, which is low, less than 15 million per ml as a cutoff. The progressive motility is around 28%, which is low, and the morphology was around 6%, which is considered normal. So this patient has an oligoasthenospermia, low concentration and low motility. So the question is this male person infertile or not? This is a debate that we're going to talk about during our presentation. This guy on exam, he had the left grade 3 varicocele, and a repeat semen analysis was done, and a month later showed similar results. So let's go and talk about semen analysis. It is for now the most reliable test that we have for patients with male and undergoing male fertility assessment. Yet it cannot fully distinguish fertile from infertile men. So even if the guy has 2 million concentration, which is less than 15 million, still you cannot say that this gentleman cannot conceive naturally. The only patients who you could say that they are really infertile who had no sperms in the ejaculate. Now, why I'm saying that, let's go back in history and see how the semen analysis cutoffs have evolved. From 1980 to 1987 to 1992 to 1999 until 2000, which has, I would say, the most clear evidence of a cutoff. And how did they get this cutoff of 2010? It was done basically on a study for more than 2,000 men who are basically fertile. So all had children naturally. So, and what they did is that they went to the 5th percentile and they took the cutoff. So the volume was 1.5 ml. The total count of sperms was 39 million. The concentration was 15 million per ml. Total motility of 40%, progressive fertility of 32%, and the morphology of 4%, viability 58%. Saying that there is some patients, which is less than the 5th percentile, where they conceived actually and had kids. So that's why I'm stating that even though the cutoff is some patients have less than the 5th percentile cutoff, but we could say we should not deem them as infertile or sterile. So this guy had, as we said, a grade 3 varicocele. So what is the actually the grades of this varicocele? So there is actually either subclinical or clinical. Now for clinical varicocele, it's usually clearly by physical exam. So a grade 1 where you do with Valsalva, grade 2 at rest, and grade 3 actually you can see it visible without even feeling the varicocele. Now for subclinical, there is a big debate on it whether to treat it or not. Usually the exam is normal. However, on scrotal ultrasound, you'll have veins larger than 3 millimeter with a reflux. If you go on an indication for varicocele repair, it should be clinical. All the studies that has been done and published in the literature based on clinical. Subclinical had, I would say, no significant difference in neither semen parameters or pregnancy. So basically, the indication for varicocele repair for clinical varicocele, and it should be for infertile men with a female with normal fertility or reversible cause, and an abnormal semen parameter. So if you have even a patient with clinical varicocele and has a normal semen analysis, this patient should not undergo a varicocele repair. This study was published, I would actually be proud of, in Saudi Arabia. It's actually the most well-organized, randomized controlled trial published in Jeddah. And it's actually included 100 infertile couple with females less than 30 years old that underwent actually randomized. It's a randomized trial between varicocelectomy versus observation. The varicocelectomy group, they were clinical varicocele, had spontaneous pregnancy rate higher in the treatment group, and also a better semen analysis quality. So what are the types of varicocele repair? There are actually different ways of varicocele repair, but the gold standard is actually microscopic varicocelectomy. And why I'm saying that is because of the lower chance of recurrence, as well as lower chance of morbidities and complications compared with other modality. So I finished now the first case, and I will be happy to answer any questions before I move to the other cases.
So if there is any, thank you, Dr. Khalid, but if there is any questions, please type it in the question and answer.
I think we are good, Dr. Ayman. We can move.
There is one question,
Yeah.
which is asking about the signs of varicocele.
The signs of varicocele?
Yes.
So varicocele, basically, it's a dilatation of the pamperoform veins, and it's usually the way is by scrotal examination. So when you examine the patient, if you go back here on my presentation, you're gonna see like the bag of worms just above the testes. This is a grade 3 varicocele actually, because you can see it. If you don't see it, the way that you can do it is by physical examination. Sometimes you're gonna feel this bag of worms. That's a grade 2. If you don't feel it, then you ask the patient to do a Valsalva maneuver. The Valsalva maneuver by inhaling and then holding. And then you're going to see the tortuous veins palpable after the Valsalva maneuver. This is a grade 1. That's the signs of varicocele. Now, for subclinical, it's on ultrasound, and based on evidence, it's not recommended to treat them for fertility.
Okay. Thank you very much, Dr. Khalid. I hope this answered the question of the one who asked, and I think we can move for the next part of that.
Okay, so the next case is actually a 28 years old gentleman married to a 25 years old female with primary fertility for 3 years. This gentleman had a semen analysis of 2 ml and had no sperm in the ejaculate. And on exam, the patient has bilateral atrophic testis. So the question is, and then he had underwent hormones. The FSH was 16 and was high. The LH was normal. The testosterone was around 8, which is slightly low, and the prolactin was normal. So the question is this guy have no sperm in the ejaculate? Whether is it an obstruction or production? This is the big debate in this question, in this case. So usually, as we all know, sperms get produced in the testis, and then it gets matured in the epididymis, and then transferred in the vas deferens, and then it actually joins with the seminal fluid that comes from the seminal vesicles and the prostate, and then the semen fluid comes out. So sometimes you could have an obstruction, and then the patient will have azoospermia, or there is a problem with the production. The test is not producing enough sperms. So the way to differentiate is to do diagnostic testicular biopsy. It will show whether the patient has sperms or not. However, we don't do it routinely. It's only done in patients with normal FSH, normal size testis, palpable vas, and normal volume of azoospermia. And the reason that we do that is because testicular biopsies, if it's done on any case, especially in atrophic testis, this will cause scarring. This will affect finding sperms. So if you have a normal size testis, normal FSH, palpable vas, normal volume of azoospermia, these are the only indication for a diagnostic testicular biopsy. So this case clearly has an atrophic testis, has a high FSH. It is most likely a non-obstructive azoospermia. So the question is, in these cases, can we do medical therapy? Unfortunately, medical therapy for primary testicular failure, there is no evidence that you could help these patients to have sperms after medical therapy for patients with hypergonadotrophic hypogonadism. However, there is some weak evidence that if you do hormonal manipulation pre-microtezy for non-obstructive azoospermia, that they could benefit, especially in patients with Klinefelter. However, hormonal therapy has a major role in patients with hypogonadotrophic hypogonadism. And in fact, and for patients with empirical therapy with idiopathic male infertility, there is moderate evidence, but with patients with oligoteratospermia, not for azoospermia. So, should we do genetic testings for these patients, and would they benefit? These are the 3 genetic testings that we usually do: the cystic fibrosis transregulated gene, the karyotype, and Y-chromosome microdeletion, and each one has an indication. For CFTR, it's only indicated in cases where you had bilateral abscess with VAS. So when you examine the patient, you're not going to feel the VAS on the spermatic cord. And usually the other features of this, you're going to have a normal size testis, absent epididymis, and you're going to have a seminal vesicle aplasia. Most of the patients with bilateral absent VAS will have low volume azoospermia. They will have a low volume ejaculate. And when you do a CFTR, you have to test the other partner because they will have, might be a major risk that they will have an offspring with cystic fibrosis. The other tests, which is karyotype and Y-chromosome microdeletion, this is indicated for patients with non-obstructive azoospermia. So any patients with non-obstructive azoospermia, you should do karyotype and Y-chromosome microdeletion. And also, it's indicated also for patients with severe oligospermia, where they have less than 5 million per ml. Now, for karyotype, usually the most common syndrome that we see is Klinefelter syndrome, which affects 1 in 500 men. And it's the most common cause of hypergonadotrophic hypogonadism. The chromosomal abnormality is 47XXY, and they could have a mosaic type, which is a 47XXY, 46XY. They usually have a high FSH and LH and a low testosterone. And usually they come, most of them with normal volume, sometimes low volume azoospermia. However, there is a few cases where you could see patients with cryptozoospermia, which is few sperms in the ejaculate, or severe oligospermia. And these usually are the mosaic type of Klinefelter syndrome. Usually Klinefelter, in cases of Klinefelter, the success rate varies actually. And there's some studies that goes up to 50 or 60% with hormonal manipulation. However, that was in one center. However, in other centers, and most centers that I know, it's usually 30% or even less in these cases. The other features that the testicular histology in these patients are usually germ cell aplasia with seminal sclerosis. Usually they have very small testis, and if you find sperms, they're going to be one small tubules when you do microscopic sperm retrieval. The features, usually they have delayed puberty, bilateral atrophic testis, and they are usually tall and thin with long legs. They have some of them cognitive disorder with some cardiac anomalies. They also have risk of malignancy, specifically for breast and testis cancer. The other test is Y-chromosome microdeletion. Now, for Y-chromosome microdeletion, it's actually it's a deletion of some parts in the male specific Y, and affects 5% of non-obstructive azoospermia. And usually there is 4 regions: AZF A, B, C, and D. However, the regions that we test are A, B, and C only. Usually, if you have a complete deletion of A and B, there is no chance that you're going to have sperms in microdissection. There is some literature that they found in partial deletion, but not in complete deletion. ZFC, usually they have hypospermatogenesis, and there is actually 50% chance of finding sperm, as well as which is similar to the chance of finding sperm in patients with normal genetic evaluation. You have to counsel the patient and inform them that if the patient has ZFC and they find sperm and they planned for ICSI, and they had a pregnancy and a child. If the child is male, the child will have 100% chance of having Y chromosome microdeletion in only male patients. So this case, going back, primary infertility, bilateral trophic testis, normal volume spermia, high FSH, but has a normal genetic evaluation. So what can we do next? Considering that the patient has a high FSH, has no sperm in the ejaculate, the next step is to find sperm in the testis by doing testicular sperm retrieval. There is different ways of doing it. There is a fine needle aspiration, a percutaneous testicular biopsy, open testicular biopsy, and microscopic sperm retrieval. The gold standard, the best way, is to doing by microscopic sperm retrieval, higher chance of success compared with the others. Then there is multiple studies in the literature that studied that. We're going to talk about it. Now, for microscopic sperm retrieval, it's usually done under general anesthesia. Usually, we open the testis, can be open horizontally or vertically, and under the microscope, you test the seminiferous tubules. Usually, if you have heterogeneous tubules, such as the one on the upper right hand, you're gonna find this dilated tubules, which is dilated and opaque. These tubules, usually you find sperms in it, and usually in patients with aspermia, sometimes one or two pockets that will actually save the day and will have from it the chance of pregnancy and having a take-home baby. The success rate of microscopic sperm retrieval is the highest, is around 40 to 50% based on the published literature. The micro-TZ ICSI pregnancy rate is around 30%. Now, there is a debate whether we can do it fresh versus frozen. There is actually, this is actually basically based on the lab. Some labs, they prefer fresh. Other labs, they're actually comfortable with frozen. Again, there is no head-to-head studies to compare what's better, but I would leave it actually to the lab that you work with, whether to do it fresh or frozen. In our lab, we actually do it frozen. However, there is many other labs that they can do it. They do it actually fresh. Now, there is many studies, but I'm going to show you now for the success rate. It's clearly microscopic sperm retrieval with many published studies in the literature is the highest success rate. However, I want to show you even the complication rate. Actually, this study that was done in 2005 that actually showed that the complication rate compared with conventional TZ is less, specifically bleeding, fibrosis, and on testosterone level. So this is the end of the second case, and I will be happy to answer any questions.
Thank you, Dr. Khalid. And if there is any questions, we will give 2 to 3 minutes to see if there is any question or we can proceed. Looks like there is no question, Dr. Khalid. So if you want to proceed, can we proceed, please?
Sure. So this is the third case, the last case, which is a 35-year-old gentleman. And this is a common case that we see, actually, who married to a 29-year-old lady with primary fertility for 3 years. This guy had a semen analysis with oligoacinospermia, with normal genitalia, normal hormones, and genetic profile. He did ICSI with ejaculate sperms twice, and all of them failed. So what should we do? We see this, and we get this dilemma in our clinic, and as we know, I mean, that ICSI actually revolutionized the treatment of male factor infertility, and the success rate is around 50%, despite the male factor. And despite this great success, still we have some cases where with adverse outcomes coupled with very poor semen qualities. And the possible causes that was mentioned is usually either there's contaminating cells in the ejaculate, high levels of reactive oxygen species, or high levels of damage in the sperm DNA. This study that was published in the year of 2000 by Strasberger and his colleagues that include the 100 cycles of ICSI that divide in 4 groups. It showed that a male couple with cryptospermia had lower fertilization rates, embryo quality, and also pregnancy rate. So the question that was raised up and was actually studied in the literature is that could testicular sperm improve the outcome of ICSI? These are some studies that was actually published. This one is in 2008, where it includes 16 couples, where they had semen analysis for male partners that showed cryptospermia. They underwent ICSI cycles with ejaculate sperm and with testicular sperm. It showed that the pregnancy rates were higher in the testicular sperm cycles, but it did not reach statistical significance, only clinical significance. And these are for patients with severe oligospermia. Another study that was published by Benami and his colleague that includes 17 patients with cryptospermia and that underwent 116 cycles of ICSI. There was 68 cycles with ejaculate sperms and 48 cycles with testicular sperms. The ICSI testicular sperms showed a higher implantation, pregnancy rate, and take-home baby rates. That was statistically significant, and that was published in 2013. However, this study that was published by Al-Malki and his colleagues in 2017 contradict Benami's study, which include 80 patients that underwent ICSI in the same period with either ejaculate or testicular sperm and showed no difference in pregnancy rate in the 2 groups. So there is conflicting evidence in patients with severe oligospermia whether to do testicular sperm cycle with ICSI or not. What about for patients with sperm DNA damage? So we actually don't do sperm DFI routinely, which is the DNA fragmentation index. We do it in specific cases where we have a couple with recurrent abortion or failed ICSI cycles. And in that case, we ask for sperm DFI. So there are some studies that was published this one in 2008 include 18 men with high sperm DNA fragmentation index that underwent ICSI with ejaculate sperms followed by testicular sperm. It actually showed a significantly higher implantation rate, pregnancy rate with patients with testicular sperm. Another study that was published 10 years later, and a fantastic study that was published by Stevens and his colleagues that include 147 couples that underwent ICSI. They had a sperm injection with either testicular or ejaculate sperm. They actually tested the sperm DFI, the testicular sperm DFI, and the ejaculate sperm DFI, and it showed that it's significantly lower in the testicular sperms compared to the ejaculate. And that gives you a theory that usually it has this damage when the sperms get traveled from the testis till it's reached to the seminal fluid and gets ejaculated. There was lower miscarriage rates in with the testicular sperms and had significantly higher pregnancy rates and higher live birth rates with testicular sperms. Another study that was published in 2017 that included 36 male patients with high DNA damage with a prior sperm ejaculate sperm injection with ICSI. It also showed a higher pregnancy rate and live birth rate significantly compared with the ejaculate sperm. So in conclusion, for this case, testicular sperm is an acceptable alternative option for patients with cryptospermia and high DNA damage, but should not be offered for patients with severe oligoacinospermia or teratospermia with normal DNA damage. I'll be happy to answer any questions for this case.
Thank you, Dr. Khalid. We have two questions. The first question was about the previous case, which was, what is the main case that you should do testicular biopsy? It depends on azoospermia or no. The question was not clear, but maybe he means that what is the main case that you should do biopsy? Is it if there is azoospermia or there is no azoospermia?
Okay, so testicular biopsy, there is diagnostic and there is therapeutic. For diagnostic biopsy, it should be only done for patients with normal size testes, normal FSH, and palpable vas. It should not be done for patients who you suspect non-obstructive azoospermia. So if you have a patient with normal size testes, palpable vas, normal FSH, then you can do diagnostic biopsy just to rule out obstruction. Now for therapeutic, usually the indication is clearly non-obstructive azoospermia. And the best way to do it is to do microscopic sperm retrieval. It has the highest chance of finding sperms and the least complication compared with the open testicular biopsy. So if you go on the all in all, microscopic sperm retrieval is the best option for non-obstructive azoospermia. Now for obstructive azoospermia, it depends on the cause. Sometimes you have obstructive azoospermia in cases with bilateral abscess of vas. In these, you can just do a testicular, FNA or with a needle, and you're gonna find sperm. So for obstructive azoospermia, just testicular FNA can actually do the job, or with an angiocath. I hope I answered your question clearly.
Thank you so much. Also, we have another question. It says that if the first micro-TZ shows no sperm, is there any chance to repeat it or no benefit?
So usually, if the micro-TZ was done by an andrologist that is well trained, and usually I do not repeat it, because the chances that you're gonna find is very, very, very low, almost none. So I only repeat it in one indication, is if I do a hormonal manipulation prior to micro-TZ. So I usually give them anastrozole 1 milligram daily for 3 to 6 months, and then I do the micro-TZ afterwards. Although the evidence is not great for hormonal manipulation with micro-TZ, but I usually do it because this is the only chance that the couple will have kids. We do not have any other option, as in the foreign countries where they have other options. We don't have any other options. So what I do usually, I only do it if the patient did not have any hormone manipulation before the micro-TZ with the respective androgens that have done it, then I do it. But otherwise, I don't do it. If for example, Dr. Al-Bakri or Prof. bin Saleh have, and I've seen a couple of patients that they had where they have done hormone manipulation and they did micro-TZ and had no chance of sperm, I would say no. I mean, you will not have any other chance, and I would not, go and do it again and risk him the risk of anesthesia and the complications of the surgery itself. Because you have to know that also doing another micro-TZ could affect also the testis quality, and the patient could go into hypogonadism and low testosterone as well.
Thank you so much, Dr. Khalid. But I have a question. If the patient had the microdeletion somewhere else where you don't know who did it for him, would you repeat again, although the patient has a small testis atrophied?
Listen, if a patient had a testicular biopsy, or I'm questioning the microdeletion that he had, then I would consider it. Yes, I would definitely consider it. Yeah, but if for example it was done by an andrologist that I trust, I usually don't do it. I'm saying, the well-trained andrologist, I usually don't repeat it. If he had done hormonal manipulation with microdeletion, I usually don't do it. However, if I'm questioning the way that the testicular biopsy done, then yes, I do it.
Okay, thank you so much.
Thank you. If there is no more question, I would like to thank all the audience for actually attending my presentation. Once again, I thank also Dr. Ayman for moderating me. I thank also Prof. Salih bin Saleh for his well-organized meeting, and also Dr. Raad Al-Mani and Dr. Abdullah Al-Jarbour. Thank you.
Dr. Ayman, if you allow me,
yes.
If there is more time for questioning.
Yes, there is.
Actually, this is a question that has been raised many times by our colleagues in Gynae. When would you do sperm DNA fragmentation index testing? As you know, this test is not available everywhere. It's only done in specialized centers, and sometimes it's costly and time-consuming. So what is the best case scenario where you will ask your patient to do DNA fragmentation index for the sperms? That's number one. And number two, what is your message to our colleagues in gynecology who are seeing the female partner and going ahead to do intracytoplasmic sperm injection, and when the result is not optimal, they start evaluating the male partner. So when the male partner evaluation should start, after the ICSI or before the ICSI? And thanks again for your very informative presentation.
Thank you, Prof. Saleh. It's actually excellent questions. The first question, sperm DNA fragmentation index. The only indication that usually do it is actually for I do it actually is usually for recurrent abortions mainly, and whether and specifically in recurrent abortions with ICSI. But recurrent abortions in general can be done. For ICSI, definitely I would do sperm DFI. That's for the first question. The second question, honestly, I would recommend for all my gynecologists, my colleagues, is to actually start evaluating the male partner from the beginning. This actually will benefit both partners. This will actually improve actually the outcome of the ICSI quality, or even any ART that you're going to do. We have seen many cases where after evaluating the male partner, the success rate has been higher. An example that was done that I've showed you, the last case, is actually a true case where a patient had oligospermia. He underwent ICSI 2 times. Unfortunately, it was done. That was done in a private sector, and they had to pay twice, and they had a sperm DFI of actually 40. He underwent TISA with ICSI, and they had pregnancy. So I would saying is that some cases you would see actually a difference. So my recommendation, and actually this is a recommendation worldwide, is that both partners should be evaluated together, male and female. with the respective specialized person to come up with a better outcome for the couple.
Great. I will take also this opportunity, since I will take your expertise opinion also here regarding the antioxidant therapy for male factor infertility. Again, antioxidants are commonly used by urologists and urologists and also and even gynecologists. So and the notion that antioxidant therapy are harmless, if it doesn't help, it will not harm. So what do you think about this? You can see some patients who are being shifted from one antioxidant to another antioxidant for like a year or two without having a beneficial effect and just wasting money. So when would you prescribe antioxidants? What's the best case scenario here, and when would you stop it?
Also an excellent question. I did not go into details for antioxidant because it's, as you know, it's a big topic, and there is a major dilemma in it. So for antioxidants, usually I don't prescribe it to all patients. I usually prescribe it for patients with teratospermia, where they have normal hormones, mainly idiopathic cases. And most of the Cochrane studies, meta-analysis, actually showed benefit in these patients. Usually, when I prescribe it, for 3 to 6 months. Yes, it's harmless, but it can be harmful, not only from health point of view, but also economic point of view, because it's expensive as well. So what I usually prescribe is for 3 to 6 months and see whether there is a benefit or not. I do not prescribe it for azoospermia. I have never prescribed vitamins for azoospermia. There is no evidence. There is no benefit. I've never seen a patient who got vitamins and then he got sperms. There's no benefit from it, and there is no evidence. So it's only mainly for idiopathic. I sometimes prescribe it in patients with also oligospermia with varicocele as well. So mainly oligospermia. Even oligospermia with hormones, I try to give hormones before giving antioxidants. So mainly our antioxidants are for idiopathic patients, maybe with varicocele, but definitely not for azoospermia, because they're not gonna benefit from that as well. I hope I answered the question clearly, Prof. Saleh.
Yes, thank you very much. Very well said.
Thank you.
Okay, thank you so much. Thank you, Dr. Khalid. Thank you, Prof. Saleh. Thank you, Dr. Abdullah Jarboa. Thank you, Dr. Raed. And thanks for the Saudi Society of Men's Health and the Saudi Society of Obstetrics and Gynecologists, and of course, our sponsor, Sprout. And that concludes our meeting. Thank you so much.